Hello, everyone. Thank you for joining us. Welcome to the Avexia webinar series. Our topic for today is evidence and application of pharmacogenetic testing to drive precision medicine with Genomind. My name is Christopher Chu. I am the Director of Marketing for Avexia Diagnostics and will be your host for this webinar. Today, I have the distinct pleasure of being joined by exciting guests, Dr. Russell Amato and Dr. Jordan Plummer, who will be our presenters for this webinar. Dr. Amato is currently a Medical Affairs Director for Genomind. Dr. Amato received his PhD from the Department of Pharmacology and Experimental Therapeutics at Louisiana State University Health Sciences Center. Dr. Plummer is currently a medical science liaison in the Midwest region. She received her PharmD from Temple University, where she had an internship with Genomind and graduated from Temple as the class valedictorian. Without further delay, I will now turn the webinar over to our speakers.
Hello, and welcome to Genomind and Avexia's discussion on the evidence and application of pharmacogenetic testing to drive precision medicine. On our agenda today, we'll be highlighting why prescribers utilize pharmacogenetic testing in their clinical practice. We'll review the academic and government agencies that support and standardize this testing. We'll review clinical and economic evidence that supports the use of this pharmacogenetic testing. And lastly, we'll review Genomind-specific tools that may aid in implementation of this testing within your own practice. I am Dr. Russell Amato. I'm currently the Medical Affairs Director for Genomind. I graduated with my PhD from Louisiana State University Health Sciences Center. I spent the first 10 years of my career in academia, published on a lot of novel therapeutics and a lot of preclinical models of psychiatric disease, including things like depression, anxiety, drug dependence, and cognitive dysfunction. I actually started working for Genomind about 9 years ago because I wanted to see a more direct impact on patient lives, rather than publishing a bunch of papers of very few academics will ever end up reading. And presenting with me today is Dr. Jordan Plummer. She received her PharmD from Temple University, graduating at the top of her class. Dr. Plummer actually did an internship with Genomind while attending Temple University, and we were so impressed with her work ethic and ability, we offered her a medical science liaison position right after she completed her postdoctoral work at Merck, where she really gained a lot of expertise in various areas of medical affairs across a variety of therapeutic areas. Now, one of the big questions we get here at Genomind is, why even do this type of testing? What's the value? And with any new technology, what problem are you solving? Why are you introducing this? Well, as you can see in the epidemiological data presented here on the slide, drug-related adverse reactions result in almost 3.2 million hospital room visits per year, right? Our healthcare system spends $528 billion on drug-related morbidity and mortality. And one source of this increased risk are genes we inherit from our parents that impact the way we break down and respond to medications. This is where our technology comes in. The field of science that identifies these gene variants that are likely to have a clinical impact on drug level, adverse events, or efficacy is called pharmacogenetics. And we're going to start using PGX for short rather than say it every time. Now, our unique genetic makeup can be a factor as to why medications may not work for us, are more prone to causing us adverse events. They can even give us insight into alternative medications that may be more likely to work or interact less poorly with our gene variants, right? However, it is useful to note that there are other factors that can influence drug response, right? It's not just the genetics. There are things like drug-drug interactions, lifestyle choices like exercise, diet, smoking. Thankfully, the Genomind platform will provide tools that can account for some of these other factors in addition to providing a genetic risk assessment. Now, when you're discussing the benefits of PGX testing, we also want to be sure everyone that uses the testing also understands its limitations. For instance, PGX testing is considered probabilistic, not deterministic. This means that if the test results make you aware that a specific drug like atorvastatin may be more likely to cause your patient myopathy because of some genetic variant they inherited, usually this is the SLCO1B1 gene, well, that higher risk that patient has for that muscle weakness, it doesn't mean that the drug will definitely cause that myopathy when given to the patient, only that the data show that on average, the drug was more likely to cause muscle weakness in patients with that particular genotype, right? And so you may want to use a lower dose or consider an alternative to avoid that risk. Now, the second limitation is that PGX results are part of the clinical puzzle. These results are not the only factor that can affect drug response. As an example, some gene profiles are associated with a higher likelihood of response to stimulants for symptoms of ADHD. These are drugs like amphetamine and methylphenidate. But if your patient has a comorbid cardiovascular disease, maybe stimulants aren't the right choice after all, right? Maybe we don't want to increase their blood pressure if that cardiovascular system's already struggling. So even though genetically, right, we don't see much going wrong with it, we still need to be aware that other factors might end up adjusting our choice for that patient. Now, lastly, while there are data showing that PGX testing can improve clinical factors like drug adherence and remission rates, and we're going to discuss some of that data today, the more robust and more consistently replicated data really focuses on assessing drug tolerability. So we're going to talk a lot about adverse events. There are several organizations that publish guidelines based on pharmacogenetic data. The FDA, for instance, has a table of hundreds of pharmacogenetic biomarkers on their website. They also provide specific dosing guidance for some drugs right there in the label, and we'll come back to the FDA in a little bit. There are academic institutions like the Clinical Pharmacogenetics Implementation Consortium, which is more commonly referred to as CPIC. And that is a group, an academic group, that consists of researchers that specialize in PGX research, right? They come from major institutions across the US, and they publish these specific dosing recommendations in these high-impact journals. You also might see the DPWG, which stands for the Dutch Pharmacogenetics Working Group. They're a similar organization. They also have a lot of well-respected scientists, but they're largely based in Europe. And so they also produce those peer-reviewed published guidelines for these gene drug associations. Now, if you were interested in finding out where do they keep all this data, how do they evaluate the literature, what's the primary data source? Well, CPIC and DPWG work closely with PharmGKB. It's a fantastic NIH-funded database of pharmacogenetic research where they keep all of that primary literature, all that information related to those gene drug associations, and they give it an overall impact score, right? They give it a score that essentially will let us know what level of evidence, right? 1A, 2A, 3, 4, et cetera. And they're going to give us that total level of evidence so we know which gene drug pairings are most important. Now, having discussed the organizations that support PGX testing, we can now dig into the primary literature that evaluated its clinical utility. This meta-analysis, which was conducted by Bunka et al. In 2023, we can see the results of several different randomized clinical control trials evaluating PGX testing versus treatment as usual in patients with major depressive disorder. In this study, there were about 4,300 subjects across 8 different studies, and the authors observed a significant improvement in remission rates in the PGX tested group. These patients were about 1.46-fold more likely to achieve remission when utilizing this PGX testing over treatment as usual. And they also calculated a number needed to treat, which was a number, it was 8, right, for anybody who's interested. And similar to many just typical antidepressant trials, which the number needed to treat for those is generally around 7, right? It can aid in achieving remission based on these data. Now that we've looked at the impact that PGX testing can have on remission rates, I wanted to show a couple of other studies that looked more closely at the risk for adverse events and hospitalizations. This one, 2021 study by David and colleagues, performed a systemic review and meta-analysis examining the effects of PGX on hospitalizations compared to treatment as usual. In the analysis of 5 different studies evaluating these hospitalizations, people receiving the PGX-guided treatment, about 3,000 of them, were 50% less likely to be hospitalized compared to participants receiving treatment as usual. That was about 7,000 people in that group. Other studies that looked at adverse events, right? What we call the PREPARE study. This was the first large-scale prospective clinical study investigating the effects of PGX-guided prescribing across numerous hospitals and outpatient clinics in several European countries. In total, about 6,000 subjects completed the study, and they followed them anywhere between a minimum of 3 months and a maximum of 18 months. What they observed was a 30% reduction in adverse event risk when patients utilized the PGX testing. And this improvement was seen in both patients with actionable test results, meaning there was a drug that they were taking specifically that had a gene-based guideline, right, by one of those CPIC or DPWG groups. And what was interesting was they also saw this 30% reduction in adverse events even in patients taking drugs that weren't showing an official guideline, right? So it seemed to be protective in both groups, which was excellent to see. And so that's our data for looking at some of those adverse events and how the PGX can be protective in that way. Now, having discussed the academic research, I wanted to circle back to the FDA stuff I was mentioning earlier, right? The FDA put out a statement in 2020, basically stating that they recognize the utility of pharmacogenetic testing. From there, they actually went, eventually published a website dedicated to pharmacogenetics specifically. It's called the FDA Table of Pharmacogenomic Biomarkers and Drug Labeling. And on that page, right up at the top, it says pharmacogenomics can play an important role in identifying responders and non-responders to medications, avoiding adverse events, and optimizing drug dose. So they've continued to have that support, right, for PGX testing. And so as I turn my talk over to Dr. Plummer, we're going to move away from the more general background, which tends to be the more boring section of the talk, right? And we're going to basically focus more specifically on the services Genomind provides. So I'll go ahead and turn it over to Dr. Plummer at this point, and I'll put myself on.
Awesome. Thank you so much for that insightful PGX overview, Dr. Amato. Let's now turn our attention to the reports that we offer here at Genomind. We'll take a deeper dive into the specific genes included on our panel and explore their relevance in medication management. So our PGX tests use a quick and easy cheek swab to analyze 26 genes that can impact drug metabolism, tolerability, and efficacy of various medications. And through Avexia, you'll gain access to our neuropsych report, which can offer insights into how a patient's genetic profile may impact their risk of side effects and response to various medications and medication classes. However, to fully understand our PGX report, it's important to grasp the difference between pharmacokinetics, or PK, genes, and pharmacodynamics, or PD, genes. So I'll provide some examples today to help clarify these concepts, as our report is divided into these two sections, PK and PD. Starting first with the pharmacokinetic genes. So when considering pharmacokinetic genes, we focus on how these genetic factors influence drug absorption and metabolism, essentially determining how a patient's body processes or breaks down certain medications, and a person's genetic profile can significantly affect drug exposure and levels. On our report, we categorize pharmacokinetic genes into three main groups. So our CYP enzymes or CYP enzymes, they're responsible for the breakdown of 70 to 80% of all medications. Our UGT enzymes, which metabolize some common medications such as lamotrigine or our benzodiazepines. And finally, our transporter/efflux pump genes, and they can affect absorption of some medications like antidepressants, antipsychotics, our opioids, and cholesterol-lowering medications like statins. So the box on the left here outlines the genes that we test for. And to put this into perspective, looking at the graph on the right, we can see how some of these genetic variations may affect medication blood levels based on how slowly or quickly a person is breaking down medications. And patients may be classified in one of 5 groups, right? Normal, intermediate, poor, rapid, or ultra-rapid metabolizers based on their gene profile. And you could see on the graph here, right in the middle, you see our normal metabolizers. They break down medications at a normal rate and achieve that desired efficacy level. Our intermediate or poor metabolizers are at risk of breaking down medications slower than normal, leading to a potential higher risk of side effects and increased blood levels. On the other hand, you'll see at the bottom of the graph, our rapid or ultra-rapid metabolizers are at risk for breaking down medications faster than normal, leading to a potential risk of inefficacy due to decreased blood levels. I think this graph does a really nice job of highlighting the varying rates of drug metabolism. For instance, both of our intermediate and poor metabolizers process medications more slowly than normal. However, our poor metabolizers have an even slower breakdown rate compared to our intermediate metabolizers. Now, earlier, Dr. Amato mentioned several organizations that publish guidelines based on pharmacogenetic data, and I want to highlight a few specific examples of these guidelines and explore how genetic variations can influence medication levels. So on the slide here, you can see one of the many guidelines from CPIC. This one specifically focuses on a class of commonly prescribed medications, our SSRIs, specifically looking at citalopram and escitalopram. So both of these medications are primarily metabolized by the enzyme CYP2C19. When we consider a patient's genetic variations at this enzyme, it can significantly impact how these drugs are processed in the body. So let's first look at the top of the chart. Patients who are classified as ultra-rapid metabolizers. These individuals break down medications like citalopram and escitalopram very quickly, specifically through this 2C19 enzyme. Now, think about a patient who may have tried these medications in the past and had a lack of response. Was it a true treatment failure, or could it have been due to subtherapeutic drug levels caused by their genetic variation? CPIC recommends considering a switch to a different medication that's not metabolized by CYP2C19 to potentially avoid this issue. On the other hand, if we look at the bottom of the table, we look at our poor metabolizers, those who process these drugs very slowly. For these patients, CPIC advises starting with a 50% reduction in the dose, since the medications are likely to accumulate in the system, increasing the risk of side effects. So, by understanding how genetic variations influence drug metabolism, we can make more informed decisions about medication selection and dosing, leading to a more personalized and effective treatment for our patients. And we make sure on our reports here at Genomind to call out any dosing guidance that exists for medications on each of our reports. So the FDA also recognizes certain dose adjustments based on genetics and interactions with other medications. So what you see here on the slide, specifically highlighted in the yellow box, is data demonstrating the change in aripiprazole levels based on CYP2D6. So these levels were significantly raised in our poor metabolizers, so much so the FDA recommends administering half of the usual dose if a patient is a poor metabolizer, and you could see that in the chart there on the right-hand side. Not only that, but if a patient is on a medication that inhibits that same 2D6 pathway, we can use the example of fluoxetine, for example, they also recommend reducing the dose in half. Why is that? Well, it turns out that drug levels aren't influenced by genetics alone, but other medications that you take can also play a significant role. This is known as phenoconversion. So essentially, you could be born a poor metabolizer by your genetics, or you might take a medication that turns you into one. And this is an important factor to consider when evaluating drug responses as well. Now, what about those pharmacodynamic genes? On the second half of our report, we dive into this section and their role in how your body may respond to certain medications. So, unlike pharmacokinetic genes, which focus on how the body breaks down medications, pharmacodynamic genes focus on how medications interact with your body at the molecular level. So, these genes typically encode for the receptors or proteins that medications target, and research has shown that variations in these genes can potentially impact drug response and tolerability of certain medications. This section covers a broad range of indications and medications, including treatments for depression, anxiety, antipsychotic use, antipsychotic drug-induced weight gain, ADHD, opioid sensitivity, alcohol use disorders, and mood stabilization. For today's discussion, I'll be focusing on two key genes within this section, MTHFR and BDNF, and how they relate to L-methylfolate supplementation and exercise, respectively. Let's start with BDNF, which stands for brain-derived neurotrophic factor. The gene and the protein share the same name, so BDNF plays a critical role in neuronal growth, development, survival, and neuroplasticity, which is the brain's ability to adapt and change. And there's two common variants of the BDNF gene that influence how much of that BDNF protein is secreted, VAL and MET. For most people, they carry the VAL-VAL genotype, producing normal amounts of BDNF. However, some individuals have one or two of the MET alleles, and those with the VAL66 MET polymorphism, or these MET alleles, tend to secrete lower levels of BDNF, which can be linked to more severe PTSD symptoms, working memory difficulties, and other cognitive challenges. For those individuals, interventions aimed at boosting BDNF levels, such as regular physical exercise, might be worth considering. And let's explore some of that data. So, several studies have explored how exercise can impact BDNF levels and related outcomes. Exercise is known to boost BDNF since skeletal muscles secrete large amounts of BDNF. In the left diagram, we're looking at a test of working memory. The solid line represents individuals with the VAL-VAL genotype, while the dotted line shows those carrying a MET allele, who typically have lower BDNF secretion. The x-axis tracks improvements in working memory as individuals increase their level of exercise. So it's well established that exercise enhances cognitive functions like working memory. So we would expect everyone to show some sort of improvement, regardless of their genetic profile. However, you'll notice that our MET carriers start with a working memory deficit compared to those with the VAL-VAL genotype. Interestingly, as exercise increases, MET carriers quickly catch up to their VAL-VAL counterparts and eventually surpass them. This shows that exercise could potentially help compensate for the genetic predisposition associated with the MET allele. The right diagram shows PTSD symptom severity in U.S. veterans. While VAL-VAL individuals show little change, MET carriers who have more severe symptoms at baseline experience significant symptom reduction with exercise, highlighting exercise's potential to counter genetic vulnerabilities. Now, what about the MTHFR enzyme and its clinical relevance? How do genetics play a role in this process? The MTHFR enzyme is crucial in converting folate or folic acid into L-methylfolate. That's the active form that can cross the blood-brain barrier. And L-methylfolate is essential for synthesizing neurotransmitters like dopamine, norepinephrine, and serotonin, some of our key players in the effectiveness of our antidepressants. However, some individuals have genetic variations in MTHFR gene that reduce enzyme activity. As a result, they may struggle to produce sufficient L-methylfolate, potentially leading to lower levels of these neurotransmitters. Now we test for two common SNPs. You'll see at the right hand, top right of the slide, C677T and A1298C. And depending on the individual's genetic makeup, this can lead to a 35 to 70% reduction in the MTHFR enzyme function. The good news is that L-methylfolate supplementation, either in prescription forms or over the counter, can be given. And this may be particularly beneficial for individuals with reduced MTHFR activity, helping to improve neurotransmitter production and antidepressant response. And let's build on that previous slide and look at one of these studies. So this study focused on MTHFR variants and a prescription form of L-methylfolate. It was done specifically in MDD patients, and all the patients had MTHFR variants, right? So they were looking at if you look at the graph on the right, you can see the individuals who added L-methylfolate to their treatment regimen experience a 12-point reduction in their MADRS scores compared to those on a placebo. This finding suggests that when we consider MTHFR variants, certain patients may have a more favorable response to L-methylfolate as an augmentation to their treatment, potentially improving outcomes for those with reduced enzyme activity. And with that, I think we've covered the key insights for today's session. We hope this information has been helpful in understanding the role of PGX in personalized care. Thank you all for joining us, and we really look forward to continuing our collaboration with Avexia and bringing you more content in future sessions. Have a great evening, everyone.
For any questions or issues you may have, please contact Avexia Diagnostics by email at info@avexiadiagnostics.com or by phone 5 days a week at extended hours, 8 a.m. to 8 p.m. Eastern Time at 888-852-2723. Thank you, Dr. Amato and Dr. Plummer, for this informative presentation. Thank you all again for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics and Genomind, stay healthy, stay safe, and we wish you all the best on your pathway to wellness.